Ladies and gentlemen, welcome to the MedTech Impact Podcast, where you get to hear from leaders and innovators who are shaping the future of medical technology. I'm Kyle Cruz.
And I'm Richard Meiklejohn.
And we're your hosts of the show.
So today on the MedTech Impact Podcast, we're delighted to be joined by Kristin Nuckols, Chief Clinical Officer and co-founder of Imago Rehab. Kristin, welcome to the show.
Thank you for having me.
Well, this is super cool to have you on. We're hot off the heels of a fantastic Med Device Boston just last week, where we got to spend some time together on the Startup Pavilion and learn a little bit more about the amazing technology. So again, excited to have you on the show and get the listeners to learn a little bit more about it too. As we always like to do when we kick things off, we love to talk about the big problem being solved. So tell us, for Imago Rehab, what is that big problem you're solving?
Yes, it was great to be with you guys last week at the Med Device. So excited to be on your show today. So the big problem that we're trying to solve is helping individuals with stroke, and especially chronic stroke, to make functional gains and gain their body back years post-stroke. So in the US, there are about 8 million Americans living with chronic stroke. So that means they've had a stroke. And once you have a stroke, you have it forever. It typically doesn't just go away. So people experience some kind of initial recovery, and then for as long as they live, they are experiencing some amount of disability. And so we're really wanting to make an impact there and be able to help those folks to get better.
And so what are the sort of trends you're seeing in this space? Because I can imagine, like a lot of these healthcare problems, it's a growing problem. But in terms of the numbers, what are we seeing in the moment?
Yes, so stroke risk is increasing. The risk, I believe, by 2050 is thought to be 1 in 4 people will have a stroke. So really high. So the numbers are just increasing. And there's another trend, which is a bit of a double-edged sword. People are surviving strokes now. About a third of people used to die from having a stroke. And now, because of medical technology innovations, people are surviving them. And so this is great, except that they're surviving strokes with massive disability because they lived through that event as opposed to dying at the hospital. So that's kind of the big difference now, is that, you're getting these people who they're unconscious for X amount of time. They are, on tubes, on wires in the hospital. And so they are coming out with just enormous amounts of disability.
And the other thing, I think, Kristin, for you as an occupational therapist and a clinician and having, a real understanding of this problem, is I think there's a big shift in the number of people who can address and care for the people who are going through these conditions. And so I guess that's maybe the sort of the third part to this, is the fact it's a big problem, it's a growing problem, but also there's less people to take care of those who are affected.
Exactly. So stroke risk increases as you age, which is a little bit of what you're referring to, I think. So, we have the baby boomer generation, humongous generation in need of healthcare, high risk of stroke. And then we have smaller generations that are doing the caring. There's also a trend towards people leaving the hospital sicker and quicker. Have you heard that term before? It's very common in the medical field that we say, you're getting discharged sicker and quicker. When I was working in the hospital setting about more than 10 years ago, more like 15 years ago, people would get to stay in the hospital a month for their initial rehab. And now after a stroke, you'd stay about 28 days. Now people are being discharged in less than 14 days. I think the average is more like 10 days, 10 days of hospital rehab. So the burden of recovery is in the outpatient world, which is, leaving your house, you can't drive, leaving your house with someone or on a public transport, maybe in a wheelchair, maybe with new adaptive devices like canes, like braces on your ankle, all of these things that make it difficult for you to move around. Leave your house. Can you find a specialist that does this work? Are they accessible to you? Are they close to you? I was talking the other day with a therapist who was living in Idaho, of all places, and she said that patients would drive 2 hours to come see her because there was nothing else around. And her clinic was the clinic that provided stroke care. 2 hours one way for a 45-minute visit and then 2 hours back home.
Wow. I mean, This is insane. Like
Yeah.
Richard, there are several problems here. Kristin, you're seeing it firsthand.
Mhm.
When you say numbers like 1 in 4, I mean, that's what we're hearing, with folks with like heart disease, atrial
Yeah.
fibrillation, right?
Hmm.
Some of
Hmm.
the leading causes of death. And now stroke has,
Hmm.
is seeing those type of numbers. I mean, that's pretty daunting. You know, I'm curious, and we all are. How is Imago Rehab looking to solve these stroke problems and help these patients get better?
In many ways, but I'll try to dial it down into the digestible parts.
Yeah.
Number one, we're trying to increase access. So especially in that story that I just mentioned with someone driving 2 hours for care, what we're providing is a telerehab clinic. So instead of the 2 hour drive, the person can open up a laptop, do therapy from home. That's very, very disruptive idea for stroke rehabilitation. Even myself as a therapist, if I would have, thought in the past, I could do this therapy virtually, that would have been just a really difficult concept to understand. We think of stroke rehab as hands-on. And so that's kind of the question that people ask us, whether they're stroke survivors, whether they're therapists, physicians, they say, how can you do stroke rehab virtually? But here is the magical concept about stroke rehab. It is all about what the patient can recreate. For them to get better, they have to do hundreds and thousands of repetitions of correct movement. So if that, let's just take that person in Idaho. They drove 2 hours, their family member took off work or went with them, drove them 2 hours to this clinic. They did a 45-minute session and then they drove back home. That person is going to be exhausted. They're going to come home and say, green check mark, I did therapy. I don't have therapy again till Friday. I'm off the hook. I'm going to do not much. Not because they're unmotivated, because that's the model. You did your therapy and now you wait again until the therapy happens again. So the real model of how therapy actually works is that person comes home and begins to recreate the things they learned. They walk the way they were shown. They move their body the way they were shown in therapy. But that's not what happens because they're tired. So what we do is provide a telerehab clinic where we teach people how to actually implement these therapy principles right into their own home, into their kitchen, because we can see it, into their living room, because you can see my chair. When I get out of that chair, how am I going to do it in a way that benefits my brain and makes my brain better? So the telerehab is kind of one half, and we can explore that and the challenges and the successes there. Then also we have a technology side where we're bringing wearable soft robots to kind of be our hands in the person's home, and other sensor-based technology and devices that can go in people's homes, remote therapy monitoring, and then sort of software and AI models that can help us to do therapy in the best way. That's a lot. So maybe we pause and just talk about, you know, remote therapy and then also technology that helps us perform therapy.
Yeah, well, that's a great point, and it really is fascinating. It certainly is the future. Again, with so many folks, Richard, that we have on the show, we're always talking, and Kristen, we're talking to these founders that are trying to bring these technologies to market that allow these patients to get care in the comfort of their home without having to travel. So, I mean, the solution is clear. Tell us about that platform, that telehealth platform. How does it work? What does it look like? And how does it help the patient?
Yeah, good question. And really, it was born out of my work in the Harvard Biodesign lab with Dr. Connor Walsh, who's my co-founder. I was working for him as a researcher on wearable soft robots, like the one in my lap. So I'll give you a little, this is not what people think of as robots, right? This is, you can just crumple it up. It's a piece of fabric. But I was working in this lab on the idea of robots that could go in someone's home because that's where they have the time to do repetition, right? So working on that and being able to create devices that follow what we know in literature. How should someone move their hand? Just because you move it, does that make it better? Or do they have to try to move it? Do they need a game to follow? Do they need a protocol to follow? So being able to bring my clinician hat to that work and design robots that I would want a patient to use was really awesome. So that's kind of how partially this got started. And then also I pursued my doctorate in OT. I have a master's and a bachelor's from a long time ago, but I did a doctorate started in 2019, finished in 2020, and wrote a program for doing telehealth with adults with stroke. And this was pre-COVID. I like to point that out because it was not an answer to COVID. It happened. COVID started while I was finishing my thesis and thought, hey, we can actually make this happen. And so in that next year, Dr. Walsh and I decided to raise the initial money and, exit the lab. And so I started treating telehealth patients using this protocol. And what do you know? When you really understand a problem and you create a solution that fixes that problem, it really works. And so you really start to see changes in patients that I'd never seen before. I've been a therapist for almost 18 years, and I'd never seen people make recoveries like that.
Is the telehealth solution something that, provides this, I would imagine, right? It provides a live, therapist to be able to meet and show you how to use the technology, right? Or the device. But what about, other maybe when there's no appointments going on, but they have the product in their home? You mentioned, several hours of rehab. Now they have the ability to do this. Are there videos? Are there apps? Are there things that you're building that can help further or, just help these patients, all around the clock?
Yes, absolutely. That's a great question. So we oftentimes say, we support the patient twice a week with a one-on-one telehealth call per discipline. So they might be getting more than just 2 sessions. They might be getting, 4 or 6 sessions a week, depending on if they're getting PT, OT, and speech. And then the devices and the technology support them on the other days. So they work with us some of the days of the week, and then they have our technology, whether it's our intensive home program that has instructions on how to engage. You might notice I didn't say home exercise program. If you've ever had therapy for some kind of injury, that you get a handout of exercises to do, and that you probably didn't do them. It's really like we all know that.
Yeah, like for my foot right now.
Yeah.
I should be doing some exercises, and guess what? I might not be doing all that I should, but
don't worry. We've all been there because, nobody really wants to sit and do exercises. It's boring. You can't really see the benefit. You're like, does this make me better? Is this what does it? And so in stroke, we know that exercise is not what makes people better. It's habit forming. It's utilization of body positions that are better than other body positions. Like, I don't want to get too far into it, but you have this injured foot right now. And do you find yourself, standing on the other leg?
All the time.
Right.
Always favoring it. And if I do any exercises, it like hurts and is sore after. And I'm like, what did I do? Why am I doing this? Right.
Exactly. So in stroke, we imagine that hurt foot is the leg that's affected by the stroke. You're going to position yourself on the other side. Okay. But to make your brain better, you need to position yourself equally on both legs. So that's a habit. That's a choice. And so that's what our therapy is about. It's not about, lay down and do 10 of these and do 10 of these. It's about habit forming. It's about figuring out how to look at your life and your behavior choices as therapeutic. So we do that in OT, PT, and speech. So we've customized them to the different disciplines, but the idea is like, it's not about a list of half an hour's worth of exercises. It's about behavior change and lifestyle changes. So maybe that will come up later in our conversation about like what else we're going to do. But that's kind of, so like the platform can be as simple as a Zoom call. It's as simple as, turn on your iPad and jump in with a therapist and set goals and then figure out how you're going to accomplish the goals. So it's as simple as that. And it's as complicated as, a robot that sits in your house and you get to put it on your body and move with it, so it's like, it can be kind of low tech and it can be high tech too.
Well, Richard, I want to bring you back into this conversation here. But I am really curious too. I want to understand how the robotic hand works. I want to know, like, what does that design like? Like, how does it actually function? How does it fit on the hand? What is it doing?
Yeah. I'll give a little mini demo, knowing that some people might just be listening to this. So I'll kind of explain, but this is essentially it's a wearable soft robot. So it's a shell of fabric that goes over a hand. It was designed, I'm going to open some Velcro. It was designed with stroke survivors in our research at Harvard. So it was designed to be able to be put on at home. So right now it's just fitting over my thumb. And then there's these sleeves that are stretchy. Part of the problem that we're solving is that these folks can't get their hand open on their own. Their hand is tight. The muscles are, they're tight and sort of non-responsive. So when they think to their hand, open, essentially nothing happens, or it gets tighter. So they need to be able to put the device on without getting a hand open. So I'm gonna go ahead and just pull these over my fingers, but the idea is stretchy fabrics juxtaposed with more rigid fabrics give us a structure that we can move. So that's sort of how soft robots work. You have some materials that are more compliant and some materials that are more stiff. And so as you put force on those fabrics, you get different motions. So I don't have it plugged in, so I can't give you a full demo, but essentially in the blue parts that you can see here, there are there's a balloon sandwich. There's balloons inside there that are layered up. And so when you inflate different balloons with the tube, with the control box, then the chambers puff up. And then depending on which chamber is inflated, it pushes your hand shut or it straightens your hand out. And so they can they have to basically tell the device that they want to open or close by just the smallest fraction of movement. This version, and this is published information. So we've, published some papers about how this works. So it's all public right now. This version has a capacitive bend sensor. It's a little hard to see because it's black on black here, but it's a bend sensor so that when I displace that sensor, when I move it just slightly, it's coded to tell the machine what I want to do. So if I move it in a certain direction, that says, I'm reaching for the target or I'm responding to the stimulus on the screen. So a nuance or like a really important fact about stroke recovery is that it's not passive. So if I just hit on and this thing just goes and I'm not paying attention to it, in fact, that can do damage to my brain. I have to be intending for my hand to move. I need to want it to move. I need to tell it to move. So that's why we have gaming. That's why we have some prompting in the device. There's a tablet that goes with it. That's eventually just going to be an app on a phone. But the program tells asks the patient to move. And so that's the actual restoration part. Yes, it's important to get the hand open, but sending the signal from your brain to your hand is actually the therapy part. So you have to say, okay, hand, I want you to move now with the timing of say the game. And so that attempt at movement is the rewiring part. Does that make sense? How
It
much
sure
you know about
does.
stroke recovery?
Well, and you said this was you take a hands-on approach. You weren't kidding. So that's really cool. And it's interesting too, because, like I love how you crumbled it up, like in a way when you were showing us, because when you think about it too, I mean, when people bring anything home and it's like really not theirs, they're probably not going to treat it the best,
Yeah.
So like it's important that you have a design too, that it can be thrown around, stepped on, crumbled up, just beaten up, right? But still be able to work, function, and last. And then the cool part is too, it's like when you think about that, obviously, not to get into the whole cost and bill of materials here, but like just at a higher level on the surface, it looks like, a pretty cost-effective technology too. So when you think about scaling that, and getting it in the homes, and the cost of the healthcare systems and the providers and stuff, probably some really strong benefits there too. So really impressive, Kristin. It's so cool.
Thanks. It's been a wild ride. Not what I anticipated as a clinician. When I got into therapy in the early 2000s, I just thought I'd work in a clinic and help people to, recover hand function. I thought I'd be like a hand therapist, which is when you maybe get a hand injury. And then I learned about this world of stroke recovery, and then I haven't looked back. That's what I've been doing. But if you would have told me that I'd open a telehealth practice that grew to 8 states so far, I just would have thought that was a crazy idea.
Well, impressive is the word. It definitely jumps to mind, Kyle. I mean, honestly, like listening to you talk, you're piggybacking, I think, in so many amazing trends. The robotics, the telemedicine. Clearly, you're going to be getting a bunch of data insights when you're delivering this. And it's kind of interesting because, we spoke about the problem at the beginning and how obviously, there's technology coming in to support this delivery of care. And you ideally would like to spend more time. That was always the kind of the promise that this technology would help you have more time with the patient. But actually, the bigger problem is we're not going to get to reach these patients. That example you gave of having to travel so far to get to the point of care, this really is the only solution. So I'm kind of intrigued now about how you take this to market. Like, how do you get this in the hands of the providers so they can then reach the patients?
So that's something that we've done a little differently than many other med device companies, is that we're also the service provider. So there's one of my passions really is about clinical adoption. That being, teaching therapists about how to do therapy. We have we were taught only scratching the surface in therapy school of how to do stroke rehab, how to work with, we work with people from birth to death, and in all diagnoses, in all settings, mental health, community settings, hospital settings, you name it. And so we can't learn everything in school to get a degree. You learn a little bit about a lot of things, and then you get your degree, and then you specialize later on. So part of what I really believe is important is the idea of clinical adoption. So, that is therapists understanding the research, understanding these trends, understanding things like, activity-based therapy works better for this population than exercises. But it's hard to change the minds of thousands of therapists across the country. Okay. And so if we made a medical device and then asked people to use it, it's one thing, but we didn't think that was enough. So we actually formed a clinical side of our business, starting with just me. I was the clinical side of the business, and actually working with the patients in the manner that I understand from literature to be the most effective. So I, worked on making my understanding of therapy operational, and then training other people, and then expanding to the other disciplines. So, brought on one other therapist to do it with me, brought on 2. Now we have a team of more than 12 who are doing this across 8 different states. And our goal is to continue opening states, especially targeting states where stroke is more prevalent. And so continuing to bring this kind of therapy to more people, and also working on payer relationships. So, part of access is having care paid for, and it's potentially not the most profitable way. You can do cash-based services. You can avoid insurance altogether. But, that is not accessible to patients with stroke. Most, we call stroke a poverty sentence. You tend to lose your job. You tend to lose your ability to get around. You tend to lose, income, right? So we want this to be covered by insurances because we want it to be accessible. And, healthcare, we want people to be able to access this. And so like that's a really big important thing for us, is having a broad insurance coverage. So we have 23 different payers right now that pay for our service.
That is so awesome. I mean, this word design kind of again springs to my mind because from the biodesign approach you took to identifying this problem, to the user design, to now your business model design. And again, we speak a little bit about how hard it is in healthcare to be disruptive, but something like this is so needed. And clearly you're taking a really unique approach. I mean, it's so entrepreneurial what you're doing. I'd love to, at some point, if we have time, to dive into that side, because clearly you have an amazing business acumen taking this product to market. But again, how do you fit this into the workflow? So right now, if I'm a patient and I come to get this treatment, how would that change in terms of the current standard of care, or would it change at all?
Let's see. So I don't know how far we want to dive into the nuances of therapy billing, but you can't receive insurance-based therapy in 2 different places. So if someone else is getting the standard of care at a brick and mortar clinic, and they want to work with Imago, they can't get their insurance to pay for both of those things. So, we've had patients say, oh, yours sounds interesting, and I've done this other one and I didn't see the benefits I was looking for, so I'll switch. So they have to leave the clinic they're with. So, we do a lot of direct to consumer advertising, straight to the patients, straight to the online community saying, hey, we're out here. Have you tried therapy before? Are you satisfied with your result? And then, most often the answer is no, I'm not that satisfied. And I want to try something different. So that is an effective model. Direct to consumer can be an expensive model because you're advertising to a lot of people. Stroke is only about 3% of the population. So it's a little bit of a needle in a haystack, trying to find these exact people that want to work with us. So the other way to go about it is really clinical partnership. And so that's, finding other companies who serve the same population, but in a different way. We don't want to compete with them, obviously, but finding people who are also looking to serve these folks, and then we can both serve them. So we have a lot of, partnership that we're working on, and also communicating our message to physician communities or case management communities who can say, hey, we have, quite literally 1,000 patients that we serve, how many of them could benefit from this model? One last thing, not to go on a soliloquy, but, I made this comment about the Idaho patient, obviously rural, I would say more of our patients are urban. So telehealth might have been sort of a concept for serving the rural community, but, we're all sort of greater Boston area. And if you can avoid driving to urban centers in Boston, do you do so? I will say,
yeah.
yes, I do. Right.
Oh, yeah.
So, even folks who have healthcare resources here, it's still a burden to get to them. It's still, there's the traffic, there's the parking, there's the public transit, now do those things with half your body not working properly, so there's still very appropriate to do telehealth, even for folks who are living in an urban setting.
Yeah, and to your point, I think you could live literally 25 miles away and it might take you 2 hours. So
Yeah.
distance
Yeah.
is kind of a warped theory around how accessible healthcare is, even though we have these amazing centers on our doorstep. Getting into them is another challenge in itself. And Kyle, I think
Right.
we've spoken on, or Kristin certainly spoken a little bit about the payer aspect, the reimbursement. It sounds like that's pretty well tied up.
Yeah, and it's interesting too, because I think about also the regulatory pathway. Now, you've made some comments that you're in 8 maybe facilities today. I don't know if I might have heard you correctly, but I guess where do you stand from a regulatory pathway standpoint? Is this a technology and a device that's already 510K approved? How does that all work?
Good questions. So we don't have 8 facilities. We do not have a brick and mortar. We're a remote team. So our therapists say, if they're licensed in the state of Florida, which is one of our states, they can treat any patient from Jacksonville to Miami. So they're no longer bound by treating people who are within driving distance of their physical location. So when we open a state, we open the whole state.
Okay.
That's a really big difference for us. And we have patients in Virginia. We have people in Hampton Roads. We have people in Southwest Virginia, in Roanoke and further. So we have people all over these states. That's the really exciting part, that we're not bound to be within certain geographical locations. So the other question was about regulatory. So the device that I showed is still under an IRB. We need to register with the FDA. It's a 510K exempt process. So we're looking forward to that. Hopefully it won't be too bad. So we are able, there's nothing invasive about this device. And there's a little bit of predicate that we can base the device, registration off of. And the alternative is, say, to do range of motion to your own hand, right? So you can attempt to move with or without a glove on. So the risk to the patient is just almost non-existent. So we feel good about that. We have expertise on our team. There's our COO came to us from another robotics company and led them from a 4-person exit from MIT to a IPO. So we feel confident that we have that expertise on our team.
Oh, that's fantastic. And it's really cool to kind of now hear that, you're that 510K exempt. I mean, now your pathway to the market is a lot shorter, faster time to revenue. That's fantastic. And I guess, Richard, it's funny, right? Because Kristin is over here just absolutely crushing this podcast. I mean, literally you were meant, Kristin, for this type of technology. It's really exciting to kind of hear you talk about everything in the challenges, the solution, your vision. But Richard, we know it's not all rainbows and butterflies.
Oh yeah, and you've spoken a little bit about the things that are coming up in the future. So I'm kind of wondering, like, what are the challenges on the horizon? Like what lies ahead that kind of maybe concerns you, and you think, it's a problem that keeps you up at night. Hopefully not too long, but like I know we have a lot going on in our startup world. So in terms of what's coming up, like what are the big problems you see?
Let's see. Well, the idea that stroke risk is increasing is stressful for everyone. So that's something that the numbers are increasing. We hope to be one of the players in the field that's helping to reduce this problem. What else keeps me up at night? Just patient acquisition. We need to grow. That's kind of where startups sit. You're looking for the investors are looking for a hockey stick, right? So we just turning on the gas and trying to grow in all these different states. There's this intricate dance between identifying a state that makes sense for us, identifying clinicians in that state, or licensing therapists into that state. Some states are fast at that. Some states are slow. Texas will just stamp you and keep going. So we love Texas. But some of the states are really slow to process the paperwork to add a business or to add to add clinicians to their state practice. So yeah, those are some of the challenges. There's just this dance between, how much do we need a certain state because there's a lot of higher stroke population, and how fast is it for us to be able to add a clinical service to that state. So just there's a lot of nuance that we have to keep track of. I will say, the therapists love it. It's amazing for us to have a work from home option. That does not exist really in therapy. Like our job is dependent on us typically being physically present with patients. So, to have the option to work from home is really novel in our field. So we have, therapists just beating down I won't say door because there's no physical presence. So they're beating down my inbox, trying to join our team. And yeah, so the patients love it too, because they say these amazing quotes like, I've never done therapy like this before, or it's so easy for me to participate in my session because I didn't have to get in my car. So, if the model works, people love it. Fundraising is hard. I will say that right now, like that's something that keeps me up at night, is just like fundraising is really hard these days. And so, that's something that is a lot of work.
All pretty common challenges here, right? Nothing that we haven't heard before for sure. But if anyone's, ready for those to take on those challenges, it's you, Kristin. Now, what about the product side, like from a kind of future milestone standpoint? How do you see kind of the product evolving over time? Are there other products too that you want to develop for other parts of the body?
Good question too. Yeah. Yeah. So, there's kind of a discussion in this field about, or when you talk about robotics, is something an assistive device or is it a rehab device? And so my argument is always that those are closer linked than people might originally think. So we want our device to be portable. They should be able to wear it around. You want to have them sit and do what's called massed practice, where they sit and get several hundred repetitions of movement. Great. But then they want to walk to their kitchen and open up the cabinet. So what if they could still have the device on, and when they want to move, they get assistance to move? So that's that habit forming. That's, if you do all these repetitions at the table and you got better, great. But then you walk to the kitchen and you try to open the cabinet and you can't, well, then you're frustrated again, right? And you had a negative experience. So if you can have a robot that assists you in your daily life, then you can have these positive experiences, and that kind of fuels your recovery. So, smaller, portable, a little quieter wouldn't be terrible. Um, we're working on a therapy app that helps people understand what to do from home. So we talked about that a little bit, just that support, that daily engagement that people need. We have working prototypes of that, but we'd love to make it bigger. And then also we want to expand into different categories of rehab. So I kind of mentioned that earlier. This is about behavior change. So any condition that can be improved by positive health behavior changes could be feasible for our model. So, one of those is cardiovascular rehab. So people that do need to exercise, but they need to exercise, for goal directed reasons. Like you don't want to do 50 squats just to do 50 squats. You want to do 50 squats so that you can get off the couch that's low at your daughter's house when you're there for dinner on Saturday evenings. So it's about making things goal directed, not just do 50 squats, but do these squats because when you're at your daughter's house, you won't have to ask for help. You see like why that makes it more important to the person, and then they're the person driving their rehab instead of do 50 squats because I told you to do 50 squats.
It makes total sense. And maybe, Kyle, if you get that therapy through to you, then yeah, you'll be following what's intended.
Call us, Kyle.
That's it.
I will, yes.
So I have a couple of questions I want to tie together here. Spoken a little bit about your team through this discussion, and I'm kind of curious because it sounds like you've just got this really clear approach to market. So I'm wondering, what have you learned about growing this team and how you go to market? And if I'm an occupational therapist and I want to join, how do I do that?
Yeah, good question. So, I'm glad that it sounds very organized and strategic, but we've gone through iterations about how to do this and how to do it in a way that is financially responsible and how to do it in a way that, works. And so, we did accelerators that helped us iron out our go-to-market strategy, like Mass Challenge, as well as the AARP accelerator. That was an amazing program. So if someone's listening who's a really early stage and hasn't done, they're not finished with the accelerator stage, and you have kind of an aging tech type of platform, check out AARP for their accelerator. They have been amazing, and they have an age tech collaborative group that once you graduate from the accelerator, then you're part of the age tech collaborative. And so that support is ongoing. They've been phenomenal. And one of the things they did was allow us access to interviews with stakeholders, physician stakeholders, and payer stakeholders, saying, what would you pay for? What do you want? What are you looking for? And so that was just completely incredible for us. And we can't put a price on that. So learning that from the field. And we have amazing investors too, who are, they meet with us regularly and they give us their wisdom and help us to refine our story. So those is definitely not like out of my entrepreneurial head. I always said I would never open a business. So, I just eat those words a lot. I watched my dad run a business from our kitchen table, and I didn't want to do that, but I've had help. This is definitely not something I did on my own. We have an amazing team. We have amazing investors who give us their time and their expertise as well.
What's in store for Imago Rehab in the next, say, 6 to 18 months?
Yeah, great question. So, more states. Right now we're operational in 8 states. We'd like that to be 13 in the next 6 months. There's the cat I mentioned earlier, who might join the call. Yeah, we'd like to expand states. Eventually we want to be in all 50. We have to do that. There's some amount of money and time that's required for every state. So we're not doing them all at once. Of course, we want to bring this to everybody. We want to expand our clinical team. We want to expand the devices that we can bring to market. So we still, partner with the Biodesign Lab at Harvard and are working in collaboration with them on some grants to continue to develop technology that could be used by this population and other populations.
So a pretty clear big vision, I'd say there, Kyle, like in terms of wanting to reach all the patients everywhere, because ultimately you spoke about at the very beginning how big a problem this is with the 1 in 4 that could be affected by this. And so, it's amazing to hear that plan and that vision. Back to what I was a little bit asking before, like if I'm an occupational therapist, I'm an investor,
yes.
I've got some money, how do I get in touch? What's that kind of the best way to reach out to you?
Sure. LinkedIn is a great way. We put lots of updates on LinkedIn, myself and our business. So Imago Rehab, you can find our page. You'll contact me that way, as well as looking for my name on LinkedIn, Kristin Nuckols. Just send me a message. I have a Calendly link. You can schedule a call. And then other members on our team, like Chris Dugan, our CEO, and Jean Tacey, our COO. Feel free to contact any of us.
Awesome. Well, if you were just listening and you want to see a demo of this product that we've been talking about here, check it out on the website. It is super cool. And we can't thank you enough for coming on and talking about this, Kristin. This is so exciting what you've got going on here in terms of reaching patients. But I think this whole model you're taking is so exciting in terms of it could be disruptive, but equally it could impact and help so many people.
Thank you. Thanks for the platform.
Awesome. Well, ladies and gentlemen, another huge thank you to Kristin Nuckols, co-founder of Imago Rehab. And thank you for tuning in for another episode of the MedTech Impact Podcast. I'm Kyle Cruz.
And I'm Richard Meiklejohn. Until next time, keep innovating.